We could go. Good morning, everyone, and thank you for joining us today. Welcome to Quality Insights presentation on improving outcomes with medication management. My name is Courtney Masterson, and I will be your moderator today. To ensure that our presenter can be heard throughout the presentation, all participant lines have been muted. We do encourage you to submit any questions that you have via the chat box. We will be collecting and monitoring it throughout the presentation, and we will discuss them at the end of the presentation. If we do run out of time to address your questions, we will answer them directly via email. And now I have the pleasure to introduce you to our presenter today. Lisa Lowry Deal is currently the Director of Pharmacy at the Sun Behavioral Hospital, Delaware. Lisa has been practicing as both a pharmacist and a nurse for over 20 years. Dr. Deal received degrees from, from Virginia Tech, Johns Hopkins University, and the University of Maryland School of Pharmacy. She is a nationally recognized public speaker, and her most recent public health efforts have been related to emergency preparedness and the COVID vaccine hesitancy. In her free time, Dr. Deal spends time with her family traveling and enjoying the beach in Lewis, Delaware. Thank you, Lisa, for joining us today, and please feel free to take over the floor.
Hi, everybody. It's really great to be here. As Courtney said, I am a consultant pharmacist with Quality Insights, and I'm really happy to be talking about hypertension and medication therapy management and how you can collaborate with pharmacists. So within this presentation today, I'm going to first introduce MTM as a concept and talk about its core elements. I'd also then like to talk about hypertension specifically, looking at some of evidence-based medicine. And then finally, I would like to introduce some of the projects and different programs that Quality Insights has that's available to your physician practices, to your care centers, and how Quality Insights can help you out as an organization. If you're not familiar with Quality Insights, it's already in the title. We are an organization that's building a foundation to improve quality of patients' care, making them healthier, and helping them spend less time at the doctor's office and more time enjoying life. We have projects that include peer review programs for VHA. We have contracts with CMS and their innovation and network program. We look at quality of home health agencies, and we do a ton with clinical measures and the quality of care that patients are receiving at different practice sites. So we're striving to be an agent for change and improving the health of the community. So what I'm going to be talking about today is a program or programs that are improving diabetes and hypertension. And what we offer at Quality Insights, because we are a grant-based program, these are programs that have no cost associated with them. So we get the grants and then we pass on those benefits to you and your organizations. Many of the projects that we utilize and are talking about today are funded by the Delaware Division of Public Health through the CDC grant. So everything that I'm going to talk about with you today is something that's available to your patients and your practice and is at no cost. So let's get into something that's near and dear to my heart, which is medication therapy management, or MTM. You might have heard this in the media. There's a lot of legislation that is being brought to the table with regards to pharmacists as providers and pharmacists. How can pharmacists bill for services? And MTM is at the core of what that legislation change is. So what is medication therapy management? It is an umbrella term for things that involve medications, right? So we look at comprehensive review of patients' medications. We look at medication-related action plans, and we look at documentation, referrals, and follow-ups. But what's really important, I think, is that we all feel that at some point, something's got to give in your practice, right? when you are talking to your patients, do you always do the best medication history known to man? Are you always going to ask what type of over-the-counter medications are you taking? What injections have you received? What vaccines have you received? Are you getting something from a different provider that you didn't tell us about? A lot of patients assume that every doctor knows every single medication they're on. And as pharmacists, we're medication experts. And so having a dedicated provider or a pharmacist that's able to really sit down with those patients and understand how they're doing with their meds is really important. For example, I had a patient who I was talking to just recently, and at looking at her prescription fill history, it really looked like she was not getting her blood thinner filled on a regular basis. And she told the provider she was taking it every day. But when I showed her the evidence, hey, Susie Q, it looks like you haven't been taking your Eliquis every day. And she was like, well, I haven't because I can't afford it. I'm in the donut hole and I'm going to have to pay for the entire thing. That's when the pharmacist can get to the crux of the issue, and switching her to a generic like Coumadin, while it takes more monitoring, sometimes that's how we can get the patients what they need. So there's tons of evidence that show that pharmacist-led interventions within a community setting at an outpatient practice can really change outcomes. Specifically, there's data looking at blood pressure and achieving blood pressure control. And we know that through these various studies that pharmacists can make an impact. And sometimes it's just calling your patient out. A lot of times as a provider, you might not have the opportunity to look that detailed information about how many times did you fill your blood pressure medication or your diabetes medication, but a pharmacist is going to afford that opportunity to look at all of that information because they want to know exactly what that compliance picture looks like. And so we've done a lot of data. This study was from in 2014, and there's more that have been published afterwards, but this was kind of a landmark trial that looked at pharmacists' impact on patients and their blood pressure. And so just by having phone calls and visits with the pharmacist in the office, they were able to reduce a statistically significant amount of the blood pressures into a normal range. So when we talk about MTM, there are some core elements. And if you look at this graphic right here, you can see that it really constitutes a lot of different things. Starting with the medication therapy review is really important. And with Medicare and Medicaid, you might hear it be called a CMR, or comprehensive medication review. It just depends on if the patient is a Medicaid or Medicare recipient or not. But that medication therapy review is a pretty extensive review of the patient's medications, going through every single thing that they've taken, really understanding their allergies, over-the-counter medications, and coming up with something we call the best possible medication history, the BPMH. And so I think if you think about what you do at your site, you're not always going to do the best possible medication history. But if you can start with a really good medication history, you can continue that on and update it at every visit. And you're always going to have a better source of truth than anyone else. And so what I do in my practice when I'm doing MTMs is then I develop a personal medication record. So I'm going to print that or email it to the patient or send them a screenshot of it so that they always have it on their phone, in their hand, in their wallet. I have a lot of elderly patients, so I encourage that they carry their medication lists of their significant other so that if they have to go to the hospital, that they'll have that list with them. And then they can edit it as things go. They can write on it. And the next time I see them or talk to them, I'm able to update it and get them a new list. The next thing that we do a lot of is medication-related action plans. If you tell your patient, hey, Joe, I need you to go and I want you to only eat 1,800 calories today, and that's it, and you don't give them a specific diet, it's going to be hard for them to follow. And the same kind of thing happens with medications. With a medication action plan, we kind of give concrete recommendations. Joe, I want you to take your medications at least 6 out of 7 days this week. If you get 100%, we're going to, give you kudos and really reward him for what he's done. But giving them patients that, giving them encouragement and giving them concrete ideas of what they need to do is really important, and it helps them become more successful. Many times when I'm talking with patients, I end up having to intervene and referring them back to the providers because of an issue that I found. For example, when that patient wasn't taking their blood thinner, I had to let the doctor know, hey, I don't know if this is the appropriate medication for this patient. She's in the donut hole. It's really complicated. She doesn't qualify for assistance programs. We need to get her anticoagulated, and this is how I think we should do it. And by having that set up for that provider, it takes away the stress of like, oh my gosh, what do we do now? What medication should I try? Because the pharmacist is able to kind of get through that pretty quickly. And then documentation is critical. With all of the quality insights programs, we do a ton of documentation so that we can look at metrics, we can look at what we're doing good, what needs improvements. And it's really nice to be able to see that information in the chart. When I update that medication list, it can be in the electronic medical record, and that can help the provider subsequently when the patient comes for continued visits. So as I've already kind of mentioned, the MTR is that medication review. It's very comprehensive, takes a lot of time that you guys don't have in your practice. And then that personal medication review, that's where we can give the patient either a list, a screenshot. I've helped many patients even just type it into their health section in their iPhones so that they have that list, so that when they go from provider to provider, that they're able to see what the patient takes. It's really interesting that we haven't got to the point in our lives where we have more of a universal health record that helps us do this better. And until we have that, it's really important to consider pharmacists. So here's an example of the medication related action plan. As I talked about a little bit earlier, it's very concrete, right? It has the patient's name, it has their pharmacy and the provider, and then it tells them exactly what they want to do. You want to take your potassium and you want to check your blood pressure. And if it's over this number, then you're going to do this. So by having a very concrete plan, some of our patients' health literacy isn't the best, so the plan might have to be adjusted based on that patient's health literacy. But by having that plan, you have a measurable endpoint that you can look at, and you can understand if this is something within the patient's wherewithal to even do, and also if they're successful or not, and how you want to continue treating them. We might not start a patient on a risky medication with a lot of side effects if their health literacy is low, because they're not going to recognize if they're having adverse sequelae. So medication action plans are really great for getting the patients engaged in their care. I think when they see it handwritten out or written out, they do a much better job of, okay, I've got to do this. I've got to take my potassium, because if I don't, my blood pressure is going to drop and I'm going to be in the ER. So we're focusing on hypertension today. So I would be remiss if I didn't bring up our good old friend, JNC 8 guidelines. It's really important at Quality Insights to practice evidence-based medicine. So at Quality Insights, we work really hard to make sure to review all of the data and make sure that you guys get most of the data. So when the new guidelines come out, we have a team reviewing them, synthesizing the data, and putting it into usable chunks of information so that it's not a 450-page brief about all of these things, and we can digest it for you and then send it into the community. And we'll talk about that in a few minutes. As you guys recall, the JNC 7 guidelines talk about a normal blood pressure and then the stages, so pre-hypertensive and then stage 1 and stage 2. We really want to catch those pre-hypertensive patients. That is the area that we want to make sure that we are trying to target. And with lifestyle and dietary interventions, you can target those patients and you can help them not get to stage 1 or stage 2. Because once you're diagnosed with hypertension, you're diagnosed with hypertension. And so it's important to really to prevent the issues that can happen from long-term hypertension, the strokes and the heart attacks, the renal dysfunction, and kidney dysfunction. That's what we want to prevent. So we need to make sure that we're consistently looking at our blood pressure goals. I know it's crazy, but not taking their blood pressure when they first get into the office is so critical. I can't tell you how many times I go into the doctor's office and my blood pressure is high because I just ran in, I was running late, I was nervous, blah, blah, blah. So it's really important to think about when you take that pressure, let the patient sit for a minute, go through their medication history and other history before you take their blood pressure. Don't make that the first thing that you do because it can be falsely elevated. And then we want to think about our blood pressure goals as we get older, or if we have any comorbidities like chronic kidney disease or diabetes. We're a little bit more aggressive with our diabetics and chronic kidney patients because we need to make sure that we are not adding insult to injury with the disease states they already have. So think about these blood pressure guidelines when you're thinking about your prescribing practices. If we look at this map, and this data is a little dated, it's from a couple of years ago, it's looking at the prevalence of hypertension in the country. And if you look at Delaware, even though we're tiny and you can barely see it, Delaware's, not doing a good job of hypertension. We're not doing a good job of managing it. And there's so many ways that we can manage blood pressure issues, whether it's diet, whether it's exercise, and whether it's medications. Patients 20 years and older, we have a need to treat them. And a lot of times, diet and exercise are not something that's achievable for a lot of patients, whether they don't have access to appropriate foods or a gym or even, a phone with a screen that they can watch a YouTube exercise video. It's really important to consider that we might need to consider medication sooner than later. And it's important to understand that Delaware right now, as it stands, isn't as healthy as it could be. And so Quality Insights is really geared towards making sure that Delaware becomes healthier, and doing a good job with managing hypertension is one of those ways. So how do we treat hypertension? Now, I could talk for hours. I could give like a whole seminar on how we treat hypertension and all of the side effects of medications and stuff. But I want to kind of highlight a couple things. And the first thing is that in the general population that have no medical comorbidities, meaning no diabetes or chronic kidney disease, that we want to make sure that we're looking at starting a medication sooner than later. Because as we know, a lot of time diet and exercise just aren't going to get the patients there. So our old standbys like thiazide diuretics and ACE inhibitors are really great. But I want you to think about your patient population. When we look at African-American or Black patients versus non-Black patients, we know that calcium channel blockers or thiazide diuretics work better. And I can't tell you how many times I see patients that weren't started on an appropriate medication based on the literature. And from that literature, we know drugs like amlodipine work better in African Americans. So that's something to consider. It's really important that if they do have CKD or diabetes, that we try to get them on an ACE inhibitor or an ARB. And we are looking at their potassium at follow-up in a couple of months, 6 months probably. So it's really important to think about what comorbidities the patient have, what ethnicity and background the patients have, and then always incorporating diet and exercise into the management plan, but considering adding a small dose of a medication to start sometimes is that one moment that the patient's like, oh my gosh, I have to start a medication. If I have to start a medication, this is crazy. that can sometimes be the impetus that makes patients go, I have got to get on the straight and narrow because I'm going to be going on a downward slope and it's not going to be good. So sometimes starting meds sooner than later is actually something that really brings patients to understand that this is serious. We always want to maximize the first medication you add before you add a second drug. I know it's really easy to add a thiazide with, another drug in a combo pill, but try to optimize it first and titrate as needed. And always remember to look for those medication side effects. I'll highlight ACE inhibitor coughs here. I had a patient that was having an ACE cough, and when I was doing one of my MTM sessions, I went through and made sure there was no other etiology. She wasn't having COVID or COPD or anything like that. And it was just a dry hacking cough that once she stopped the lisinopril, it completely stopped. So that can happen, and it's important to be cognizant of that and teach your patients that. And that's something that pharmacists have the time to do. They have the time to sit there and be like, ACE inhibitors can do this, this, and this. They're really great at lowering blood pressure, improving kidney function. They really protect your kidneys, especially if you have diabetes, but they can increase your potassium. They can cause a cough. And in rare circumstances, they can make your mouth swell up, and it can be a medical emergency. So it's really important to think about those things and discuss those with your patients. And then, of course, if a patient's failing therapy and have tried one med and maybe needs two and then maybe three, that's the point, where we may need a more extensive workup. We may need, to call in another specialist. But at the very basics, this is how we would initially manage hypertension. So I was talking about some of the other initiatives that Quality Insights has, and one of those is called the Healthy Heart Ambassador Program. And this is a blood pressure monitoring program. Again, everything I'm talking about today is free of charge. And this Healthy Heart Ambassador Program offers support for 4 months, looking at a Bluetooth enabled blood pressure monitor. It sends over the data. Then the patient has biweekly checks with a health coach, has monthly nutrition education sessions online. There's cooking sessions and demonstrations. And then there's other topics that are thrown in there, smoking cessation, diabetes prevention, all of these things that help improve the heart and make sure that the patient's living a more healthy lifestyle. So Quality Insights is an advocate for this program and is able to recommend patients for this. They have to be over age 18 and they have to have been diagnosed with hypertension, but they should not have had any cardiac events like an MI or a thrombus or something. If you would like to recommend, you can directly referral your patients to this. I find that the patients that do best with this kind of program are patients that are somewhat non-compliant, but want to become compliant. You've had those patients. You can see they're right on the cusp of having success. Those patients that are starting to become motivated, I think they do a really good job, and the coaches really help them get to that point where they're going to take over their life and really improve their lifestyle and management of their blood pressure issues. Another thing that we want to do is promote medication adherence. And that's, when I'm managing hypertension and diabetes, medication adherence is critical. And so we have a lot of modules available. Most recently, this was in February of 2022, looking at medication adherence. There's like a toolkit that's available. It looks at how you can improve your workflow so that you can incorporate medication adherence into your interviews with patients. And you can get this module at the Quality Insights website. Some of the module topics, and we utilize this acronym called MEDS, where we look at medication adherence and how we can improve that with our patients, engaging pharmacists, utilizing Quality Insights to get a pharmacist to your practice, delivering effective communication to our patients. I think it's really important not to talk above the skill level of your patients. And sometimes it's, a circle, you're going to have to draw the pill and be like, we're going to take this circle pill today. And you have a square pill tomorrow. So it's really important to educate your patient and communicate with them in a method that is appropriate for them. And then supporting the providers and the patients, all the different tools that we have available for the patients and for your practice site is something that's available within these modules. And they do a great job of just breaking down this information into quick, useful chunks. It's not like something that's so extensive that it's just going to cause you to be like overwhelmed. It's really just nice, useful chunks that you can go in, take this piece and use it for Mr. Jones and use this piece for Mr. Rivera. So it really helps get those information to the patients in the practice. We also provide academic detailing. We have hypertension academic detailing. We have all sorts of topics. We have diabetes, we have dialysis. There's so many different academic detailing that we have. It can be one-to-one provider education. We can do education with an entire practice. If you want to get your whole staff together, we can do education for clinical staff, for providers, for non-clinical staff that you really want to start to promote advancement. I think it's really important to include your entire staff in some of this, because sometimes it not only helps them understand what their patients are going through, it helps them get to the point where they're going to be a better patient and they're going to start taking care of themselves. And like I kind of alluded to earlier, I think it's really important that we really stick to all of the evidence-based guidelines and data. And we're going to take all of those journal articles and guidelines, and we're going to break it down and get it to a couple of slides that really point out the highlights, so that you're not spending all of your time reading the journals and the guidelines, but actually spending time with your patients. So I think that it's an amazing resource. And again, it's all free because of the grants that we get. Some other resources that we have, you can see here, there's applications to help patients remember to take their medications. And we also have the Million Hearts campaign, which is a way that we can track adherence to improve our patients' care. So there's so many more resources that are available within Quality Insights and the programs that we offer. One of the things that I incorporate into my patient discussions is something called the Adherence Estimator. And it's a survey about a new prescription. And it asks just 3 finite questions. It asks, I am convinced of the importance of my medication. I worry that my medication will do more good or do more harm than good. And I feel financially burdened by my out-of-pocket expenses. And so you can estimate how compliant a patient would be by their answers to these questions. If they're not convinced their medication is important, they're probably not going to take it. If they worry about the side effects, they're probably not going to take it. And if they're financially burdened by it, of course, they're not going to take it, because we know that if they have to choose between their medication and their rent, sometimes those are decisions that our patients make. And this estimator, it really helps me understand what my patient's going through. It doesn't ask what's going on in their lifestyle. It's a little bit more of a way to ask them without making them feel bad about things. And so my patients do a really good job of answering this, and we get to the bottom of the issue. And does that mean we have to change medication? Sometimes. Does it mean more education? Usually all the time, because they just need to understand that they are, that what they need, what medications they're on are what they need to improve their health and their lifestyle and get them back on track. We also have care team modules, which are really focusing on collaborative practice between physicians, mid-level providers, just providers in general, and the pharmacist. We want to make sure that the pharmacy team is incorporated into the program, and make sure that we can use them for what they are trained for, which is experts in medication. So our pharmacy team does a great job with this, looking at the practice module and looking at all the different partners that you can utilize for your practices. And then finally, Quality Insights has something called Edesco, which is our online learning platform. And we have things like medication therapy management public health series. And that was developed by the Delaware for Pharmacists Society. And that's just one of the education programs that we use, but there's so many that are available. They're free courses and they have a lot of information if you want to become certified in something. It's really an amazing program that offers so many different education modules and modalities. And it does a great job of, again, something in a finite period of time, gives you that information, and then allows you to go on about your day. So I know I've talked about a lot of topics about this presentation. Ashley Briscardi is I directly report to her. So if you have any questions or comments about Quality Insights or how pharmacists and MTM can change your practice, please reach out to her. She would be happy to discuss things with you. And then I'm not sure if Courtney, if there were any comments or questions that we can have. I know we're running a little bit ahead of time, so I can take any questions or comments that you guys have.
So far there haven't been any questions in the chat. I have been dropping resources in there. If anyone does have any questions, please feel free to put it in the chat. Just unfortunately, in our experience, when people come off mute to ask questions. So Ashley actually had a question for you, Lisa. How long usually is a MTM session with patients? Oop. Oh, we just lost Lisa. We'll give it a minute or two to see if she can get back on with us. You know, we all have internet issues. In the meantime, I did want to ask everyone if they can. We do have a post test for this session. Okay, so Lisa just texted me and said that it's usually 30 minutes with a patient and that she will be back on in just a second. Excuse me, if we could just give her 1 second and drop any questions that we have in the chat for when she gets back on. In the meantime, I will show you guys just quickly what the post test looks like. So this is the post test. It's very quick. All questions that were answered during the presentation. You should have received these slides this morning, so you can also reference back to those to just, excuse me, answer these questions. We just want to make sure that you guys are receiving the information that we're trying to convey to the people on. So please feel free, or please go and answer these questions just so we can make sure that you know, the questions were answered. Oh, Lisa's back. Okay.
I'm so sorry. My computer died. My charger was plugged in, but not all the way, and it died. So I apologize. But MTM normally, I don't know if you answered it, but it takes about 30 minutes to really go through a patient's medication history, because I really like to go through everything that they've taken. I like to talk about medication, like what they've had in the past. So especially, I work in behavioral health now. So it's really important for me to understand what they've tried in the past with blood pressure medication. What did they try in the past that failed? What have we already worked through? Usually that initial session takes about 30 minutes. And then I like to have subsequent sessions that usually last about 15 minutes. And on those sessions, we're really looking at focusing more on compliance, how they're feeling, how can we actually reach those goals even further. You know, I do small goals. So for example, I had a patient whose blood pressure consistently ran 180s over 110s, which is the diagnosis of hypertension or hypertensive emergency or urgency. But, you know, he lived there. And so my first goal was just to get his diastolic less than 100. And, you know, that was a small goal. But when we got to that point, then I was able to say, okay, buddy, let's try to get it like 160 over 90. You know, that was our next goal. And by having those more achievable bite-sized goals and those subsequent follow-ups, I understand that I'm not going to change their lives in one visit. And so by having these subsequent follow-ups just for 15 minutes at a time, not enough that they get frustrated or annoyed, but enough that they get re-engaged and excited again about, you know, the good work that they're doing. And I think just being a voice of encouragement is really critical.
Okay, so we did have another question come through. Where do these MTM sessions usually take place?
Oh, that's a great question. So the majority of my MTM sessions are actually tele sessions. So I utilize either some sort of HIPAA compliant platform that allows video sessions, or I use the telephone. Some of my older patients, they love using the telephone, and I'm fine with that. I can get a lot of the information that I need. And then a lot of times I do have some curbside consults. So if I'm at a practice making calls and they're like, Lisa, I've got this really complicated patient, he would really benefit from an MTM, you know, then I would see the patient in the office. So I would say the majority of them are telephonic, but then I do get a lot of curbside consults as well.
Okay, fantastic. And how many MTM sessions would you say are needed usually to help a patient meet their goals?
That's a great question. I think that it depends on the patient. I would say one initial session that's about 30 minutes and 3 15-minute sessions. So you know, about a little bit over an hour of discussion with the patient, because again, I want to like pursue better goals for that patient. So so usually about 4 sessions. And then, you know, some of my patients, I think they would want to have an MTM every month for the rest of their life if they could, just because they want to talk and chat. But you know, it depends on the patient.
Okay. And what are some of the, besides, you know, direct patient consults, is there anything else that working with a pharmacist can, you know, can help in your practice? In the
Yes.
practice?
Yeah, absolutely. So, for example, I know prior authorizations are probably the bane of a lot of offices visits and the MAs who are completing them. But as a pharmacist, we know the lingo and the criteria that patients need to get them approved. We know the criteria and the words you got to use in those prior auths to get the medications approved. So one of the things I do is I don't do all the prior auths, but if there's one that, you know, we have been trying to get this Ozempic, and I'm not recommending any of these meds I've talked about. I'm not recommending them. I'm just using them as examples. We need to get this Ozempic approved for Mrs. Jones. How can we do it? We've tried every single injectable agent, and we're not getting any of those approved. And, you know, it's putting that data down. So we doing a lot of prior auths when needed to help these patients get on the medications that are best for them is definitely something that helps out. And then, I mean, honestly, updating that medication list is something that is so imperative to improving the patient's care, because then you know exactly what they're taking and all the interactions that could potentially happen when they come in for that sick visit and you want to start them on a macrolide antibiotic and they're on amiodarone or something. You know, it's really important to have all of that down.
Okay, so we did have another question come in. So Jason said that, or he's asking if there's any suggestions for getting patients to take their statins, that he sees a lot of resistance to side effects and, you know,
Yeah, that's a great question. I run into statin hesitancy is how I call it. The patients just don't want to take it. They hear that they're going to get, they don't call it rhabdo, but they're scared they're going to get leg pain and, you know, that it's going to be more harmful than good. So I commonly say, all right, what if we start you on the lowest dose possible? And I want you to see how you do for a month. I'm going to give you a month. If you can guarantee that you will take this for a month for me, and then then you can switch them back up to the dose that they really need, even though it's probably more of a placebo effect than actually really lowering their cholesterol numbers. I think that starting them on smaller doses and saying this is the smallest dose available, but I want you to try it. I don't think you'll have any side effects. I've seen a lot of patients do really well with that. I also, the proof is in what they do. So, you know, when you consistently are seeing their LDL and their LDL go up and their HDL keep going down, I know you're not doing the work, Mr. Jones. Like, we've got to do something. I don't want you to have a heart attack. And fish oil is just not cutting it these days. I think that having those honest conversations with them is also important. But starting them at, we're big in behavioral health right now with micro dosing. We're talking a lot about different things with different hallucinogenics that we're going to potentially use in behavioral health. But micro dosing of statins is something that we're starting to see just to get the patients started, so that once they get started, they understand, okay, I'm not going to have rhabdo. My legs are fine. You know, I'm not having any of these adverse sequelae. Patients will become less hesitant. Great question.
Julie was asking, what time are these services offered? Is it after normal working hours?
So I think it depends on what your practice wants. Quality Insights is going to make the services available for when it works with your practice. Personally, I love it when they're after hours because, you know, I have a Monday through Friday job. I'm a consultant here, so it's nice to have off-hour additional work, but we're going to be very flexible and make it so that it's something that works with your practice.
Okay, great. Cindy was wondering, is MTM evidence-based? So if you could just maybe discuss a little bit more of what the evidence that MTM is based off of that you discussed during the presentation.
Sure. So right now I'm working on the 1815 project, which is the diabetes and hypertension project. So before we even have people go out into the field and do the medication therapy management, you know, they're doing training on diabetes and hypertension. I just focused on hypertension today, but looking at the anti-hypertensive, like the hypertension guidelines, you know, that's how, you know, we're focusing in on, for example, if I get a patient, they're like, Lisa, this is a hypertension patient. I'm going to look through all of their meds and I'm be like, why the heck are you on, you know, this medication when you never even tried, you know, some of the gold standards. So that's some of the recommendations I'll make are, you know, patient with diabetes, never had hypertension before, was not started on an ACE inhibitor, would recommend starting lisinopril at this dose. And while it's evidence-based, it's also, I tailor it towards the patient's insurance or lack thereof insurance. You know, if they're telling me that they're going to lose their insurance next month, you know, I'm going to be looking at the $4 lists that are available at everywhere to see what I can get these patients so that they can not only start a medication, but then remain compliant. So it's definitely evidence-based. People that perform the MTMs have training, and then the recommendations that we send back to the providers are those that are going to follow that evidence and hopefully make an impact in their blood pressure or their diabetes markers.
Fantastic. And which would you say is better? So you had mentioned that sometimes you'll do, you know, consults within the practice. Would you say that when the patients are home that it can really benefit them because they have medications there, or do you think that they're great? I
think kind of like everything else, it depends on the patient. Some patients need a little bit more talking to. You need to be a little bit more aggressive or just a little bit more stern with them, and having that face-to-face interaction is really great. But having them at home, every patient goes to their medication, wherever their medication is, whether it's a pill box or a lot of them just have like a little like Tupperware filled with them, and I can hear them rattling around. But they will go in and bring their medications on the phone, and then they tell me what colors they are, and they can tell me if they need a refill. They can tell me the actual prescription number so that I can facilitate the refills much more quickly. I guess I didn't mention that, but a lot of times I capture patients that are getting ready to run out of their medications because I really enforce that you need to refill your medications with when you have 7 tabs left. Whatever that is, you cannot wait until you have 1 pill left, because the way the pharmacies are these days, they're having just as much shortage of personnel as every other employment that's available. So it's really important to get those refills in much more quickly, to be able to get them their medications and for them to stay compliant. So it depends on the patient, but I think that the older population loves the fact that they don't have to get in the car and come here. They love the fact that someone's calling them on the phone, and they really become engaged. I think it's pretty cool to see these patients who are 70, 80 years old, and they are so engaged in their care, and they're really open about and honest about what issues they're having, whether it's financial or side effects. And sometimes that non-face-to-face telephonic interaction actually is helpful for certain patients, our shy patients, or patients that are a little more honest when they're not looking at you face-to-face. And then again, we have that other population that really needs, me to stand up and put my hands on my hips and be like, Mr. Jones, this isn't good. So again, it depends, but there is a niche for both.
Okay, great. And does MTM look at what pills the patient may be taking outside of prescribed things, for example, like supplements?
Yeah.
Like, is it kind of a more holistic look?
I mean, we look at everything because of the fact there's so many drug interactions. So if someone tells me that they take ginkgo biloba or echinacea, those can really impact like your clotting cascade and your ability to form clots. And so, that's something that I'm going to talk to the patients about. Like, for example, if they're on certain medications and you're eating grapefruit or caffeine or nicotine, that can really inhibit or excite certain enzymes in your liver. And so it's really important to ask those things. So not only do I ask about their prescriptions, but I am very consistent in asking them, do you take any topical medications? Eye drops, for example, eye drops like timolol, which is a glaucoma agent, it can lower your systemic blood pressure. So patients might not think that eye drops are important, but sometimes those eye drops can actually work in conjunction with oral medications to lower blood pressure. So topicals, eye drops, over-the-counter medications, Tylenol is a biggie. We used to say no more than 4 grams a day. Now we're down to 3 grams a day. And patients may think, well, I can take as much Tylenol as I want. It's an over-the-counter agent, but it's really not. I mean, if Tylenol was presented to the market today, it would be a prescription medication. So it's really important to ask those questions. So I ask about over-the-counter pain meds, over-the-counter oral supplements. I really get on my soapbox a lot of times about all of these additional supplements that haven't been reviewed by the FDA, that haven't been looked at, and just making sure that they are doing their due diligence, because some of these supplements that now are being sold on third-party markets and things, we don't know what's in them, and they could have a lot of serious sequelae with patients that are taking a lot of medications. So it's a comprehensive review. I wouldn't call it holistic, I'm just calling it comprehensive. So we're looking at everything across the board.
Great. Lisa, do you mind me telling about the Flonase?
Oh no, go right ahead.
So I've been working with Lisa. I am a type 1 diabetic, and I honestly have been compliant with my insulin pump because of what the adhesive does to my skin. It makes it very itchy. I do my injections. I'm compliant with my insulin, but I don't always wear the insulin pump because of the reaction that it causes on my skin. And actually, Lisa was able to give me a tip that my endocrinologist had never heard in 30 years of practice, which was to put Flonase on the skin first. So it's a steroid and it creates this film between. And I've been able to wear my insulin pump since she told me that with no skin reactions. My endocrinologist messaged me today telling me I've been telling patients this, I've been passing this on to everyone. Like, it's so exciting for people who have insulin pumps, because an insulin pump, it is adhered to you typically for 3 days, depending on it. But the one I have is 3 days, and it can cause a lot of skin irritation. So That was a tip that she was actually able to give me. I got my own little MTM session. But so, it is great. And it's something that I never really thought to bring up to a pharmacist of, well, I'm having these skin irritation. Is there anything you recommend? And Lisa, literally 3 minutes, she was like, oh, try this. It's been fantastic. So, it is something that I myself had never really considered. But it's been such a help. So at this point, we've covered all the questions that were put into the chat. If anyone has any last minute questions, please drop them in there. If not, you can feel free to email Ashley with any questions. We welcome any questions about whether it's quality insights or about MTM. We would really love to help your practices in any way that we can. So please feel free to explore those resources that I was dropping into the chat. And if anything comes up, please email us. We also really ask that you fill out that Survey Monkey that I showed you. I'm dropping it into the chat again, so that way it's widely available to everyone. And we really thank everyone for joining us today. I hope it was a good use of everyone's time, and that they learned a bunch about MTM and about what Quality Insights has to offer.
Thank you guys so much for having me. I appreciate it.
Thank you, Lisa, so much for joining us.